Okay, so I think this is one of the harder systems to learn, and that's just because there's a lot of new terminology, and the baby's heart is much different than the adult heart. So, we're gonna talk about that. So we know that the heart has four chambers, right? We know that there's the atrium, right, which fill, and the ventricles that pump. We know that there's different pressure systems. So we have the left side, which is the atrial side, which is the higher pressure system, right? And we need that because that's going to promote um, systemic circulation. So it needs a higher resistance and a higher pressure to do that, to meet the needs of the body. Whereas the right side is the venous side, and it is the low pressure system. And that is it needs a lower pressure because it's not going to rush into the lungs, right? The lungs need a lower pressure system, and that can only be provided through the right side. And it's also because the right side is carrying deoxygenated blood from the body. It doesn't need as high of a resistance to do what it needs to do, or as high as a pressure as the left side does, which is something I believe she even tested you on the difference of the pressure systems. Another really interesting thing is that the venous circulation, or the SpO2 range for the younger population, or the little babies, is that the venous circulation's oxygen saturation is actually 65 to 85% compared to the normal range of arterial circulation, which is 95 to 100%. So we expect for the venous side to be between 65 and 85, whereas arterial, we always know, is going to be 95 to 100. We know that normally blood is going to flow from a high to low pressure, right? And blood flow typically wants to take the path of the least resistance. Now, last thing I want to point out is that for cardiac output, that is the volume of blood ejected by the heart in 1 minute, or how much of blood, right? And this is dependent on the heart rate of the child up until about 5 years age. So depending on how fast their heart pumps, is going to affect the cardiac output, or the volume of blood that's going to be ejected in 1 minute. And children are at a particular increased risk for heart failure, and that's because the muscle fibers of the heart are really not very well developed, and they also have an immature heart. So that's why kids have a higher heart rate, because their body needs to try to compensate to get all the blood around that it normally can't do. So the child's heart has to work much harder normally just to get blood out to the rest of the body compared to that of their adult version of themselves, right? And there's also a lot of anomalies that are present at birth that also increases the risk and causes heart failure. So let's talk about that fetal circulation, right? Remember that ductus venosus, which is basically when blood bypasses the liver through the ductus venosus. Um, but we said, oh, when we clamp that umbilical cord and cut it, that duct, that shunt closes, right? Problem solved. There's no problem anymore. You clamp the cord, that duct that bypasses blood from the liver closes. Then we have the foramen ovale, or what we call an atrial septal defect, and a ductus arteriosus, or what we also call a patent ductus arteriosus. Both of them somehow bypass the lungs, right? So for a baby in the foramen ovale, or the atrial septal defect, blood is going to enter, right, the right atrium, and the blood is going to flow from the right to the left here. So from the right to the left from that foramen ovale, right? It's going to bypass the lungs and just go straight right from the right atrium to the left atrium, and then it's going to go to the left ventricle and then be shot out to the rest of the body. But once you're born, it closes. The ductus arteriosus, right? It's the opening between the aorta and the pulmonary artery, which bypasses the lungs and sends blood there. And remember, we said that this one, if please correct me if I'm wrong, is the shunt that takes a few hours after birth to close. Am I right with that one? I think this is the one that closes a few hours after birth. Like I said, you can correct me if I'm wrong. Um, but we know this one doesn't close as soon as the baby is born. So we know these shunts. Um, we understand that this is how a baby's heart should function. And after, a few hours after birth, all of them are closed, right? Some close immediately, some close a little later, right? So for assessment, we have to look at their present illness and their past medical history. We also want to look at their prenatal history, specifically for the mom, right? So when we're talking about the mom's OB history, we want to look at how their labor process was, how their pregnancy was, because congenital heart defects form by the end of the 8th week of pregnancy. Because remember, we talked about after the 8th week, we get into that fetal period, right? And they're no longer an embryo, but they're actually starting to develop organs, right? So if they're gonna have any sort of congenital heart defect, that's gonna be the time. Cardiac abnormalities, that's going to let me know when that baby's born, they might have a cardiac defect. They're going to have feeding difficulties. They're not going to feed properly, okay? Or what we call a failure to thrive. They're going to have a change in color with crying or feeding, okay? They're going to look a little different. They're going to have an increased risk for respiratory infections. They're going to have weight gain, or failure to thrive, right? So they're not going to always be as hungry. And they're going to be very tired, and they're not going to have as high activity level as the other children around their same age. And they do not play a lot because they have a decrease in activity. If we see any of these things, we're already thinking cardiac abnormality. Now, on physical examination, we're going to see potentially cyanosis. So, we want them to have an SpO2 of 95% or greater on room air. That's probably not the case with someone who has a cardiac abnormality. Digital clubbing, white nails and the beds of the nails are unusually shaped. That's what we'll see with in a baby who has a cardiac abnormality. Chest wall retractions, if we see that on visual inspection, indicates there's something going on with this baby. Other things that we should look for is the heart rate, right? We know an infant has a higher heart rate because, as we said, they don't have a strong muscle fiber, so it takes them much longer to push out blood to the rest of the body. So we're looking at 90 to 160 beats per minute for an infant that's less than 1 year of age. 1 to 3 years, and then preschooler of 6 to 12, we're looking at 80 to 115 beats per minute is normal. And sorry, not 6 to 12. What am I saying? It's like sorry, 3 to 6 is preschooler. From school age, when we're talking about 6 to 12, and adolescent 12 and older, they're going to have more of a normal heart rate, which is 60 to 100 beats per minute. Their heart sounds, we also want to look at that. We're going to auscultate that and say, do we have murmurs? Remember, we could hear some abnormal movement in the beginning, first few hours. Remember that ductus arteriosus doesn't close right away. So we might hear a little extra heart sound. But it depends when we hear it, right? If it's a couple days after, not normal. A couple days after birth, I mean. For respiratory, if they have adventitious breath sounds, they're having retractions, something's wrong. We also, you'll see why, we need to look at temperature and we need to look at pulses. Pulses, we need to compare their upper and lower extremities, right? And for blood pressure, we want to compare their upper and lower extremities, and you'll see why. Capillary refill should be 2 seconds or less in infants and toddlers, but a prolonged refill of greater than 2 seconds is going to indicate poor cardiac output and perfusion. But you can do a cardiac assessment without a respiratory assessment, okay? We could do a focused cardiac on these patients, and that's okay. But, sorry, what did I say? You cannot do a cardiac assessment without a respiratory assessment. And that's because as we're seeing with these symptoms and the management, is that if you have a cardiac abnormality, they're also at risk for respiratory infections and respiratory retractions and adventitious breath sounds because they are also becoming hypoxic, right? And some of this is going to be due to some of the abnormalities in those shunts. Some of them may or may not close, which is why there are respiratory complications. So if you're going to do cardiac, you have to do respiratory. Sorry, that's my fault. I read it wrong. But okay, so we have a different medical treatments. We have oxygen to give for respiratory distress, heart failure, and hypoxemia in patients. We are monitoring how well they are breathing, so how the work of their breathing and their pulse ox. We want to do chest physiotherapy to promote any sort of mucus clearance and mobilization of secretions through like percussion or vibration. Um, and other drugs that we could give besides oxygen could include alprazolam or prostaglandin. Know that it opens the ductus arteriosus, but it can cause apnea in infants. I would know that. I would know that because she asked about that. For digoxin is another medication we can give for babies, especially who have heart problems. It helps increase the contractility of the heart, which helps with patients with heart failure. But we need to know that the therapeutic window is between 0.8 to 2.0 nanograms per milliliter. We need to auscultate the apical pulse for 1 full minute, and there must be specific parameters to hold digoxin. We're not just going to hold it. Signs of toxicity include lethargy, bradycardia, nausea, and vomiting is the most common symptom, though, in children for toxicity with digoxin. And remember, we already talked about that babies and younger children are more prone to adverse effects with medications. We also talked about, right, when we know digoxin, we know that we need to take the apical pulse for 1 full minute because we're not going to give digoxin if the heart rate isn't within a normal range, because one of the things that digoxin can do is it can cause arrhythmias. So the heart rate needs to be normal to not to hold, to give digoxin. We could also give furosemide or Lasix, which is a diuretic typically used in kids. So furosemide, good for kids. Usually give it with food or milk. And like we do it for furosemide, right, we got to look at especially those potassium and sodium levels, have strict INOs, have daily weights, hydration status of mucous membranes. Is anything looking dry, right? Their blood pressure. We also want to monitor that fontanelle, especially that anterior fontanelle. The anterior fontanelle in babies under 18 months, and photosensitivity in older kids. Sometimes I get confused. So if you hear me second guess myself, just because I don't want to say anything. I'm not 100% sure. But I remember when I had her, asked us a question about alloprostol, the prostaglandin, and that it opens the ductus arteriosus but can cause apnea in infants, whereas indomethacin, which is an NSAID, it closes the ductus arteriosus. So I would 100% know that. But know that she's going to ask you which of the following would you give to open the ductus arteriosus, or which of the following would be to close the arteriosus in a child. Okay. And you might be wondering, why would we want to open it? We'll get into that, why we'd want to open it. But we talked about the pathophysiology. We talked about the heart, how it works in kids. But now let's talk about tetralogy of Fallot, which is a congenital anomaly or a heart defect in infants and children. It's usually associated with Down syndrome. Now, there's four major characteristics that of tetralogy of Fallot, and I would know each of them. Is one, they have something called a ventricular septal defect. So there's an opening between the ventricles. That is one characteristic of tetralogy Fallot. The next is that they have pulmonary stenosis, where there's obstructed blood flow from the right ventricle to the pulmonary artery. So it's hard to get blood there. There's also an overriding aorta. So there's an enlarged aortic valve over the right and left ventricles. And there's also right ventricular hypertrophy due to the pulmonary stenosis, right? Because the right side has to push even harder to try to get blood flow from the right side of the heart to the left side. That's causing the heart to become hypertrophed or thicken, that muscle thickens, okay? Now, the characteristic besides those that lets you know, like manifestation wise, hey, this child has tetralogy of flow, is that they have what we call cyanotic episodes. So, cyanotic episodes is what's going to let us know, hey, that this patient has tetralogy of flow. It's actually one of the defining manifestations compared to all of the other ones. So, this is because they have right to left shunting still. There's still a problem here where it's not going through the lungs. There's a problem. It's not getting to the lungs, which means that the body is not being able to have oxygenated blood because this is a baby who's born now and it should be working properly. They're not having oxygenated blood. It's not going through the lungs to be exchanged. And blood is going to start recirculating the venous blood back into the body, which is another reason why they're having these cyanotic episodes. Now, the how much cyanosis depends on the degree of pulmonary stenosis. Know that. So we already said the increase of cyanosis depends on the degree of pulmonary stenosis. So that also translates to the greater the right to left shunting there is. So the more blood, more of that deoxygenated blood coming from the right side that's going to the left, the more cyanosis occurs, okay? If it's mild stenosis, the oxygen saturation may be normal, it might not be as bad. Now, because there's a ventricular septal defect, there's this opening between the ventricles of the heart, right, which is supposed to be closed, we could hear a harsh systolic murmur. As we said, anyone who has a heart problem will also, babies will start to show tiring with feedings and have poor weight gain. The heart is also going to show on a chest x-ray as a boot shaped. And in toddlers and up, not infants, in toddlers, they're going to have chronic hypoxia compensatory mechanisms. Know that. In toddlers, not infants, the way their bodies are going to do that for toddlers is they're going to have clubbing of the fingers and they're going to have polycythemia or elevated RBCs to compensate for the lack of oxygen going around to the rest of the body. So, for management, this is really important. It all depends on their age and the degree of cyanosis. For a preterm infant, you're going to have continued infusion of prostaglandin E1, which was that alprazolam, to maintain the ductus arteriosus to relieve the respiratory distress. We want to keep the duct open to alleviate respiratory distress, okay? But the side effect is that they're going to have apnea. And if they have apnea, that means this child requires intubation. For an infant and older, we have to monitor for worsening hypoxia, that these patients are going to have what we call TET spells. And these are like really super cyanotic episodes, which we call TET spells, and they're usually self-limiting after 10 to 15 minutes. If they have one, they're going to look pale, they're going to be tachypnic, they're going to have crying, feeding, all these problems. The priority intervention when we see a TET spell, and for someone who has tetralogy of Fallot, who's an infant and older, they're going to be put into the knee chest position to decrease the blood return from the lower extremities and increase it to the lungs, okay? Because we need to get as much blood to the lungs as we can until surgery, but we need to keep the duct open only for the preterm infants, okay? So when we do the prostaglandin E1, it's for the preterm infants who have tetralogy of Fallot, okay? But that's because, remember, a preterm infant is already born with probably no surfactant, probably no alveoli, depending on how early they were born. If we close that duct, the lungs are going to just crash and break because they cannot gas exchange. So the duct needs to remain open until they're old enough and it can be closed, okay? But the side effect is apnea, so they need to be intubated to keep them getting oxygen. For infants and older, they have surfactant, they have alveoli, okay? So they're not getting prostaglandins, but they're having TET spells. And those TET spells, how we treat it, no needed chest position until they can get surgery. Okay. When they get surgery, that's the only way we can repair the defects during infancy of tetralogy of Fallot. Like I said, it all depends on the degree of cyanosis. So another thing I want you to know is that for toddlers and up, they'll squat a lot. Squatting is letting them know that they're having like these little TET spells, and they'll do that to naturally increase oxygen to the lungs. Infants can't do that. They can't stand. That's why. But toddlers and older children will squat instinctively because they'll know to do this knee and chest position. Infants can't. So you have to actually manually put the knee to chest. Toddlers, yes, if they have a TET spell and they're not doing it, you should, but they'll do it instinctively. They'll squat because they know somehow that they need to get blood to their lungs. Even though they're like 1 to 2 years old, they know what to do. Okay. And another thing is that only tetralogy of Fallot and another congenital cart defect of transposition of the great arteries are cyanotic heart problems. The other heart problems that we're talking about are not cyanotic. So just keep that in mind. Another congenital heart problem is atrial septal defect. So we talked about the atrial septal defect is the foreign ovale. So that means it stays open. We said it was going to close when they're born. Oh, sorry, no, it stays open. This is causing left to right shunting. Okay, so now, because what did we say? Normal blood flow, high to low. The left side is the higher pressure side, so blood starts going to the left, to the area of lower pressure, which results in a larger right atrium and ventricle, secondary to decreased right ventricular compliance, because there's just too much going on. And there's an increased blood flow in the lungs, which can lead to pulmonary hypertension and congestion because everything's backing up, right? It's backing up in the lungs because it's all trying to go back to the right side, to the lower pressure side, and everything's building up. So remember, this is left to right shunting. Know that. Manifestations could be asymptomatic. They could have adventitious breath sounds. Depending on how big that atrial septal defect is, it might just close on its own, but they could have a little murmur. Because remember, it's an additional opening in the heart, so you could have a murmur. They could have recurrent upper respiratory infections, because as we said, we cannot separate cardiac and respiratory assessment. And as they age, they can experience more dyspnea and fatigue. So, remember how we said aspirin, not good for children? Actually, the exception is one of them being atrial septal defect. If they have them, they're going to be treated with a low dose aspirin for 6 months after the procedure. If they're having a procedure called an interventional cardiac catheterization, and that's to fix these issues and promote blood flow and help reduce all this overfill in the lungs and stuff. Okay, so to prevent all this clotting, to prevent an MI, things that could happen post operatively. This is where we say it's okay to give low dose aspirin. Okay. Another thing is we can give diuretics and digoxin because they could have heart failure and things like that. But remember, atrial septal defect, left to right shunting. So think about it. It's going to the right side and everything's backing up. Where it came from is backing up in the lungs and is backing up into the right side of the heart. The next thing is a ventricular septal defect. So we said one of the characteristics of tetralogy of Fallot is that they have a septal defect. Besides all the other things that they have, know all those 4 characteristics. But besides that, they also have left to right shunting because instead of this being an opening in the atrium, it's opening in ventricle. And what do we just say? We're going from high to low pressure. The low pressure side is the right side, so it's left to right shunting. This also increases blood flow in the lungs and can result in pulmonary hypertension and congestion. So it could be asymptomatic like the other one, the large defect, usually symptomatic within the first few weeks of life. It all depends. Just sounds exactly like atrial septal defect, right? Depends on the size, if they're going to be symptomatic, right? They both will have tachypnea, dyspnea, feeding difficulties. There could be a harsh, a loud systolic murmur at the left lower sternal border. They could have heart failure. They have heart failure with rule of thumb, heart failure, kids, digoxin, furosemide. And they could have surgical management to patch it closed. But this is pretty much the exact same as atrial septal defect in terms of how it works, left to right shunting. The only difference is where the opening is. This is an abnormal opening in the ventricles, whereas for atrial septal defect, it's an opening in the atrium. For treatment for atrial septal defect, you'll give a low-dose aspirin. After their surgical procedure, you won't do that for ventricular septal defect, but the manifestations are still the same. Okay, there's another heart condition called patent ductus arteriosus, PDA, and it's congenital, okay? So you were born with it, right? It's a failure of the fetal duct between the aorta and pulmonary artery to close after birth, right? So remember, we said the patent ductus arteriosus is when we have that opening between the pulmonary artery, well, it's a shunt between the pulmonary artery and the aorta, so blood goes straight to the aorta, bypassing the lungs, right? It's one of the it's most common in preterm infants, and it's also left to right shunting. Why is it left? I would know and write down which ones are left and right. Because she does ask which ones are left to right shunting. So left to right, because there's an opening between the pulmonary artery and the aorta, which means where is it going to go? The side with the lower pressure. And the right side of the heart has lower pressure than the left side. So from going from high pressure to low, goes to the right side, which is going to cause what? Pulmonary issues, right? So tachypnea, dyspnea. They're also going to have poor feedings, poor weight gain, right? They're, depending on how enlarged it is, there could be murmurs, and there's a lot of shunting, and it really just depends on how much shunting there is. If it's really big and there's a lot, it's gonna have more symptoms, and if it's smaller, they could be asymptomatic. You see that there's a lot of similarities between PDA, ventricular septal defect, atrial septal defect. Therapeutic management, once again, digoxin, furosemide, heart failure, increased caloric formula for infants. Remember, these are not, they're having failure to thrive, poor appetite, and poor weight gain. We want to close it. But here's the thing that differs from the other ones, right? For medical management, there's two ways. If it's a preterm infant, we're going to give indomethacin to promote the ductal constriction. If they don't give that, they can give a prostaglandin to open the ductus arteriosus, but it causes apnea, okay? I would know that for management, especially medical management, this is what we may do, okay? And I would write down which ones do left to right shunting, and I would know cardiac and respiratory go together, so I'm expecting, since they have cardiac issues, right? I'm expecting, because these are all these openings in the heart that shouldn't be there, I'm expecting murmurs and I'm expecting respiratory complications. And because it's a cardiac abnormality, we're always expecting poor feedings, poor weight gain, things like that. Okay. But no, especially medical management, what medications you give and what medications you don't give for each of these different scenarios. Now, because I'm someone who likes to compare things, I've actually made a chart so I can compare all of them and really see what the difference is between all of them and what to give. And I hope if you have this in your notes, it does help. But once again, out of tetralogy fallot, atrial septal defect, ventricular septal defect, patent ductus arteriosus, right? Tetralogy of fallot is right to left shunting, okay? Whereas all the other ones are left to right. I would know that. I would know that tetralogy of fallot and the transposition of great arteries are the only ones that are cyanotic, okay? Whereas all the other ones are left to right, which means all of these have pulmonary complications, atrial septal defect, ventricular septal defect, PDA, whereas this one doesn't have that as much, okay? All of them will tire with feedings and have poor weight gain. just like all the other three. But for tetralogy of Fallot, they're going to have a boot-shaped heart on their chest X-ray. And we said toddlers have a chronic hypoxia compensatory mechanism where they have clubbing of the fingers and polycythemia, right? The priority intervention, especially if they have a TET spell, right, as we said for tetralogy of Fallot, is the knee to chest position. For all of the other ones, the priority intervention is respiratory assessment and monitor for heart failure for each of these. I hope it helps. I like charts. I don't know. I think they're useful, but it just helps, I think, summarize everything that's going on so you have a clearer picture. Coarctation of the aorta is also congenital. Okay? What is the problem with this one? This one is constriction of the descending aorta, most commonly within the thoracic aorta. Narrowing of the aorta comes off the left ventricle. So what happens is that aortic valve becomes stenotic, so it becomes hard, which restricts blood flow leaving the heart. This decreases the overall blood supply to all of our organs, our lower extremities, which means systemic blood flow is impeded, which leads to heart failure and low cardiac output, secondary to left ventricular failure. There's also an increased afterload and work on the left ventricles, which leads to left ventricular hypertrophy. So remember, there's a problem with the aorta. The aorta is becoming stenotic. As a result, the left side has to work harder to get the blood out to the rest of the body. As a result, the muscle of the left side hypertrophies, problem, which can lead to heart failure. Meaning there's a smaller amount of blood that's leaving the heart to the rest of the body, okay? So in a symptomatic infant, the nursing priority cardiac assessment is looking at the difference in oxygenation color pulses between the upper and lower extremities. Remember I said before, oh, watch out for the pulses in the upper and lower. This is where it becomes important because the upper extremities are going to have a normal capillary refill, a normal pulse ox, and a normal pulse, and they're going to feel warm. Whereas the lower extremities are going to have a prolonged capillary refill, a cool body temperature, a decreased O2 stat, and a poor pulse. That's because the blood flow from the heart is easier able to get to the arms than it is able to get to the legs, which is causing the upper part of the body to be warmer than the lower part. We're also going to notice that there's a difference in blood pressure between the arms and the legs. So for this specific thing, if we suspect coarctation of the aorta, the priority is a cardiac assessment to determine the difference in, like I said, the pulses, the capillary refill, their O2 stat in the upper and lower extremities, and the priority nursing intervention is blood pressure in all four extremities because, same reason, the blood pressure in the upper extremities is going to be different than the blood pressure in the lower. And that's a key thing. I've seen coarctation of the aorta come up a lot on NCLEX prep and questions, and it always has to be related to taking blood pressure in all four extremities and the idea that the upper extremities are going to have a higher pulse, warmer to touch than everything else. Now, it does say, it could lead to heart failure, right? So we're going to expect that there's going to be poor lower body perfusion. There's going to be weakness and tingling in the lower extremities from decreased perfusion, right? And weak femoral pulses. That makes sense because everything below the waist is basically not getting as well oxygenated and not getting as much circulation. There could also be jugular vein distension if they're having heart failure in addition to that. That's what I want you to take away. The main point is that the lower part of the body is going to be weaker. We need to, as a priority nursing intervention, blood pressure, not respiratory, priority is blood pressure in all four extremities. And priority assessment is a cardiac assessment if we suspect coarctation of the aorta. Okay. The next one is transposition of the great arteries, congenital. Remember, this one and tetralogy of Fallot are the only ones that are cyanotic, meaning they cause cyanosis. And it's going to be, these patients are going to be cyanotic at birth. And what happens in transposition of the great arteries is basically the aorta arises from the right ventricle. And the pulmonary artery arises from the left ventricle. So it essentially creates two distinct circulatory systems. So instead of the pulmonary artery sending blood right to the lungs to kind of get filtered and stuff, it can't do that. They're almost as if they're two distinct systems working separately. It's incompatible with life. You're probably thinking, well, how are they going to live? They're not. Okay, this is death. This is no good because the heart is not working with each other. The right side is almost independent from the left. There's no connection. So it's incompatible with life. The cyanosis does not go away, even if you give them 100% of oxygen. Know that, okay? It's not going to go away. You're progressively going to see them destat. Survival depends on the blood mixing through the patent foramen ovale. So if survival depends on keeping the foramen ovale open, right? How do we do that? What did we say keeps it open? That prostaglandin, okay? So we also may want to keep the atrial septal defect open so that blood can be exchanged between the right and left atrium, okay? If not, they can actually, ironically, right, a defect that you typically want closed, in this case scenario, they're going to want to create a foramen ovale. And what is the management? Give them a prostaglandin to maintain the patency of the ductus arteriosus. I hope that makes sense, right? We need an opening because there is no opening to get blood from the right to left. But this is incompatible with life, and long-term survival rates can be positive if surgical interventions are prompt, but it's not a very good it's not as promising as the others. I hope that makes sense. So, the next thing that I want to talk about is heart failure and cyanosis. So heart failure, this is what I want you to know. The classic manifestations, there's three classic ones. Know that. Tachycardia, tachypnea, and weight gain. Those are your three classic symptoms. Know it like that. In children, here's how it works. Usually heart failure is not just, oh, they're born with it. It's because they have a congenital heart defect that causes it. Heart failure is not just something like you can get over time, right? This is due to some sort of heart abnormality, especially in children. And it's either due to an inadequate emptying of the heart, so some sort of volume overload or poor contractility of the heart. The heart's not able to maintain cardiac output to meet the body's needs, or they have cardiomegaly, the heart is enlarged. Regardless, it's some sort of congenital heart defect, and the main symptoms are tachycardia, tachypnea, and weight gain. Know it like that. There's also other symptoms, right? Because cardio and respiratory go together. So they can have all these other ones: altered pulses, cardiomegaly, polycythemia, digital clubbing. Yeah, they could have recurrent upper respiratory infections, squatting if it's due to tetralogy of Fallot, right? They can have poor feedings, as we said with everything, poor feedings, failure to thrive, not wanting to really eat, jugular vein dissension, all of those things. They'll need frequent rest periods. Yes, they will need that. But the main symptoms are tachycardia, tachypnea, and weight gain. So, for diagnosis of heart failure, it's made by clinical history and physical exam, chest x-rays and EKGs, and an echogram to look at the structures of the heart and the blood flow. Right? Because we said it's due to some sort of congenital. So all those things that we talked about, all those different, cardiac abnormalities can be the reason why this patient goes into heart failure as a child. Therapeutic management of heart failure includes we want to decrease the cardiac workload of the heart and increase cardiac output. We want to decrease the volume overload and increase the contractility. Only surgery can repair the congenital defect and cure heart failure. The only way you cure heart failure in a child is repairing the congenital defect. But what is in priority assessment? Respiratory, because we said whatever there's cardiac, there's respiratory. So with that being said, if there's a respiratory problem with cardiac, our priority for heart failure is respiratory. We want to look at respiratory rate, O2 stat, breath sound. So respiratory, then heart, then vitals, and then nutrition. That's what we want to do, right? We want to auscultate the heart and listen for that apical pulse and things like that. Interventions, elevating the head of the bed 30 to 45 degrees. Remember, respiratory complications promotes the work of breathing, expands the lungs, right? Minimize and stimulate and decrease the work of breathing. Maybe give them oxygen. Daily weights and strict intake and output. Because remember, what did we say? Tachycardia, tachypnea, weight gain. Gotta have weight gain, strict INOs, cluster care to decrease oxygen consumption. Remember, they get easily fatigued. Supplemental oxygen with titration, so we titrate it as needed on by the doctor's orders, and pharmacological therapy. We already talked about the digoxin, and we already talked about diuretics, what we need to monitor for, what we don't need to monitor for, right? One more thing that I want to add when it comes to digoxin, as I said, we were saying before, we don't give it if the heart rate is abnormal, especially in infants. If it's less than 90, we're going to hold the digoxin. Digoxin toxicity is typically presented in children with nausea and vomiting. For diuretics, we give it to reduce the volume overload, whereas the digoxin is given to increase the cardiac output and increase the contractility while decreasing the heart rate. Furosemide is the preferred therapy. And something else that's going to let us know, because we've said that they're at risk for dehydration, right, with diuretics, is that if they have a sunken fontanelle in children less than 18 months, that means that they have dehydration. Know that as well. Once again, the things we already talked about the digoxin and diuretics earlier, so you can go back to that later, but I just wanted to point out a few other things. We also need to have nutritional support for heart failure. So tachypnea, and fatigue, right? So that's going to cause an inability to consume adequate caloric intake. So the babies need to be in a really relaxed environment. They need to have frequent small feedings, maybe less tiring, and maybe feed them every 3 hours in small amounts to help them make sure they get food, right? Make sure they're in an upright position so that they have less stomach compression and improve respiratory effort. Because remember, it's going to be like they're having trouble breathing and you're keeping them on their side. The baby's trying to eat, but they can't breathe. So we want to try to keep them as upright as possible. Um, have maybe a soft preemie nipple or a regular nipple with an enlarged opening for them so it's easier so they don't have to suck as much, right? Something that's a little easier for them to get the food down. If the child is unable to consume an appropriate amount in their mouth, consider a nasogastric feeding. Monitor for increased tachypnea, diaphoresis, or feeding intolerance, such as vomiting. Respiratory assessment is the priority prior to feedings because you can't feed a baby that's tachypnic. If they're having signs of tachypnea, we are not going to feed them because they're going to choke, they're going to aspirate. So no. Also, they need to have rest periods while feeding because they get easily fatigued. And offer children, especially the older ones, high caloric foods like high fat, high protein so that they can get something out of it. Okay. The next thing is cyanosis, right? This means that for when we talk about cyanosis and we keep saying certain, things called cyanosis like tetralogy or fallot or transposition of great arteries, the oxygen saturation is generally below 85%. So, what does that mean? What is cyanosis? Pale, dusky blue, red, dusky blue, gray skin color, compensatory mechanisms in toddlers, not infants, is going to be polycythemia or an increased red blood cell count and digital clubbing. Nursing assessment, priority, respiratory. So we need breath sounds, O2 saturation, oxygen titration, and for interventions, oxygen, elevate the head of the bed 30 to 45 degrees, and cluster intervention so that it's not as hard for them and doesn't take as much energy when performing activities. And that's it. Any questions?